Hello everyone, how are you today? I hope you guys all doing well. My name is Hipa and I'm the assistant lead of live sessions here at Pre-Health Shadowing. I'm very happy to welcome everybody here. Welcome to our continuous students and a big welcome to any new members here. We're very happy to have all of you. We're going to go ahead and start a little bit with our introductions about who we are and what we do. Pre-Health Shadowing is a student-led organization. It's an international one. It's also women-led, minority-led, and it's a nonprofit organization that focuses on medical advancement. So all of the resources or the live sessions that we have and other departments work that we do is all free for you guys. We do like to accommodate all of our students' needs and abilities, so we do have closed captions throughout all of our live sessions. If you have any other ideas that you want us to adopt to make it more accessible and faces your accommodations, you can always email us at info@Shadowing, and we'll be very happy to take it all into consideration. We do want to make this experience as lively as we can, and it meets everybody's expectations, so you can always email us with any questions or concern how we can make it better. You can always also join our mailing list to never miss any of our future sessions or any other updates that we come on in the organization. If you want to stay more into the loop of PHS other than just live sessions and through the emailing list, you can always also join us on our social media platform like Instagram, TikTok, and also LinkedIn as well. They all share the same handles, which is at Pre-Health Shadowing. We always post there like news stories, the live sessions that we have. We do post them all ahead for you guys to know about, and also as well or other updates within the organizations with other departments. One thing that I truly love about PHS is that we host students from all around the world. Sometimes we see students from all the way over the cross overseas. So please go ahead in the chat. Let us know where you're logged in from today. If you're more interested to be into the loop of PHS other than just joining, which of course is a very big thing and we appreciate you taking the time and being here, you can also still join as a student volunteer or a team member. These are more in-depth roles within the PHS, where as a volunteer, all of the roles are voluntary, nothing's paid, but the student volunteer role is like where you can choose whichever department you want within PHS and give the time to help out with other members. While as a team member, you are enforced within one role that you are very responsible of seeing and overseeing other ones that are under or above. And then you report to other managers and all of that. They're very easy, quick forms that you can fill out on the website. We do have them in the chat for you. You can join them and just fill them out. It's very quick, just a little bit of information about you, why do you want to join, and then what time commitment you can provide for us. One thing that I truly love about being part of PHS is that it's fully remote and it's very flexible. You're not required to be anywhere in any office or any specific state or place. It's fully remote. You can work from behind of your computer. And we do have multiple departments within the organization. It's not just the live sessions. One of the very great departments we have the research, and which is like a program that matches students within the research mentors that talk to you more about research, get you more involved in it, and get mentorship into how to get in it and gain the experience of research. We do also have other systematic kind of roles where you help with the grants or the fundraising. We also have a finance, and we also have a volunteer and communication department, and even more. So you can always look into these roles and see what department if you want to loop into more of being with PHS. We don't just focus with college students, but we also do with high school students. We have a high school program, HTP, which is a program that focuses on offering high school students leadership and also as well healthcare education. It tells you how to step into the journey of going to pre-health if you're deciding on it or not. We do have multiple chapters around high schools in America, and so if you know that your high school have one, you can join it, be part of it, and learn whatever you need to get a lot of great resources for you before you step into your pre-health journey. As we said, this program is a nonprofit, and so we do like to keep all of this free for you guys. So we do rely a lot on donations. So if you can scan the QR code, donate whatever you can, even if $1 makes a difference, and if you can share it with as many people as you can to keep this ongoing for pre-health students, you know how being a college student maybe or other students can cost a lot. So we do want to provide something for you guys that keeps it as free. So if you can go ahead, donate whatever you can and share with other people, we would really appreciate it. Throughout the session, I'm sure we're gonna learn a lot from Dr. Curseen here today. You can feel free to type any thoughts in the chat or any questions that you have. We will have a Q&A section at the end, so you can have all of your questions ready and we'll get through them. Throughout, I'm sure we're going to learn a lot of stuff. We're getting a lot of resources from our professional here today. So feel free to take any notes you want to take. Also, you will have a quiz that will be posted on our website after for you to gain your shadowing certificate. So if you want to take any notes, jot it down. That would help you on the quiz. Feel free to do that. The quiz is not going to be a hard quiz. It's just a very easy 10 question, just based on what went through in the session today. Since we are remote, it's very amazing to keep it more meaningful and all of us kind of into the loop. So if you can have your cameras on, it'll keep it more engaging for us. It's like one way to keep it on going. So if you can put your camera on, we'll really appreciate it. That's all on me on my end. I'm gonna go ahead and give the floor to Dr. Curseen here to go ahead and share her slides and talk her through amazing presentation today. Doctor, are you ready to go ahead and share your screen?
Hi, is everyone able to hear me?
Yeah, I can hear you.
Okay, great. So go ahead and share. I practiced this earlier, so let's see if I can remember. Okay, looks like I can. Great. Right, and share.
Yeah, I can
I'm
see your
sharing.
screen.
Okay, great. You can see my slides. Yeah, I think it's doing a weird loading thing, but that's okay. I also if we do lose connection, I'm connected on my phone, so just put something in the chat or wave at me, and I will just flip to a different medium.
For sure, no worries. Thank you for letting me know.
Let's see. And with the slides, what are you all seeing?
It's like loading.
Let's see. It's like loading. Yeah, I've never seen that happen before, so I'm not sure.
If you want to keep it just like that and then flip
I'm sorry,
through, I
guys,
guess
just bear with me for a minute.
No worries.
Is that okay? All right. So we can
I think you stopped sharing.
and make that larger.
I think you stopped sharing.
Okay.
Can you hear me? I think you stopped sharing.
I think I got it now. I can hear you. Can you hear me?
Yeah. Yeah, I can see your screen.
You can hear me okay? Okay,
Yeah.
great.
Mhm.
So I'm just gonna see if I can make this, and you can see my screen. All right,
Yeah.
I just want to see if I can make this larger. If I can't, then we'll just go.
You can
Just go
keep it
from
like
there.
that if you feel
All right,
better
so
with that.
right now I'm Dr. Kim Curseen, and I'm an outpatient palliative care doctor, and so we're going to talk a little bit about what that is. I know some of you may have heard, I think some of you may have heard about palliative care, but I'm going to go officially through what our profession is and what our profession has to offer, and I'll also keep the chat up in case I learn, in case I blank out. I have to also apologize. I'm here in Georgia. We're expecting a storm, so everybody is losing their minds because one, we close down if there's a heavy leaf fall. And I will also make sure that your the slide deck will be available after the talk. So let's go ahead and start. So palliative care, what am I hoping to share with you today? Even the slides aren't going. Let's see. But I'm sorry, I'm still having trouble. I'm still having trouble with the slides. Let me try one more. Let me try something else.
No worries.
All right, we're gonna try one more thing. Are you all able to see my screen now?
Mm, not the slides.
Not the slides. Okay.
If you want to, you can share them with me and I can share the screen for you.
Okay. No, that sounds great. So let's see. And yeah, but were you able to receive my email?
Let me see. Not yet. Yeah, I just got them.
Okay, great. I feel like I'm inspiring you all to consider a career in geriatrics. This is what happens when it's like your parents trying to work technology and getting frustrated.
It's all right. Okay, let me share. Just let me know when you want me to switch to another slide.
Absolutely.
Okay, can you see the slides?
Not quite yet.
Okay.
Okay, great. Okay, perfect. All right, so here, let's go next slide. So we're going to start with a few patients because I think that's always a good way to introduce a topic. So many of you want to go into the medical field, and there's a ton of places to enter. So I think having this conversation will be really helpful. So I have a 30-year-old mother of three children under 10 with advanced breast cancer who works as a pastor, a 55-year-old with diabetes needing a heart transplant and has a constant burning in his feet, and he's currently homeless. 92-year-old with advanced dementia who is currently being cared for by her only adult daughter, and a 5-year-old with aggressive leukemia being raised by his grandmother. So, anyone in the audience like to think about, please come off mute or maybe even put them in the chat. Like, what do all of these people have in common?
They have a chronic disease.
Right. They all have chronic disease. What else? Okay. I see here from Sierra, they all suffer from some sort of health condition, and in care involves someone older. Yes, absolutely. So I want you to keep these guys in mind because as we move through the presentation, we will come back to these cases. Next slide. Next slide. Next, hit next. Okay. So common spaces. So they all have, like you all pointed out so astutely, they all have serious and life-limiting illness. They all need more, are going to require more than just the illness treated. And then they all have caregivers or families who are affected by the illness. Next slide. So what is palliative care? If you put in a quick Google of palliative care, what you'll usually see palliative care in hospice, you'll see a lot of end-of-life care. But actually what we do is we are the medical subspecialty that specializes in the medical care of people who are living with serious illness. We focus on providing relief from the symptoms and the stress of that illness, whatever the diagnosis is, and the goal is to improve quality of life for both the patient and the family. Palliative care is provided by a team of palliative care doctors, nurses, and other specialists who work together with patients and their doctors to provide an extra layer of support. It's appropriate at any age, at any stage in a serious illness, and can be provided along with curative treatment. So when you hear that definition, what is not there? Or like what are most people worried about when they hear the word palliative care? What do you think of? Well, end of life care, absolutely. Thank you. Thank you. Moment. That's what people hear. And often people hear death. And what I explain to people is when we are taking care of patients, I've never taken any care of anyone who's dead. We take care of people who are living. And so when you think about our profession, the vehicles with which we provide the care may be different. So we may provide the care in a clinic or in a hospital, in a nursing home, in someone's home. And yes, we do provide care, when people are in hospice, but it depends, but the philosophy of our care doesn't change. Next slide. Yeah. So next, and hit, I think one more. Oh, go back. Okay, great. So when you look at this gentleman here, I really love this illustration because when you're sick, there's so many things coming at you. And, if you look at the patient, he's sort of stuck there on the bridge all by himself with the trains and hospitals coming at him with all kinds of machinery. And that's really what it's like. Who we are, or what I try to explain to people, is that extra layer of support, we are the people that support that bridge. And even more so, in addition to being the support for that bridge, we're actually the mortar that goes in between the bricks to hold it together. So when patients come to me and say, what does palliative care do? I give my spiel, but the truth is, I do whatever they need for us at the time. So what you'll learn when you go into healthcare, it's very doctor and disease driven. So if you come in with heart disease, your cardiologist is going to take care of your heart, as they should. And that's what they're looking for. That's what they're worried about. When patients come to see us, we do care about the heart, but more importantly, we care about them as a whole person. Because we care about not only what's happening to them physically, what's happening to them mentally, what's happening to them spiritually, and socially. Because in order to have any health care or anything work correctly, you have to take care of all of these things. It's not like when you get sick, everything else stops. Life continues to go on. And those added pressures can actually interfere with your ability to have the best care, particularly when you're seriously ill. Okay, hit next. Yeah, so yes, absolutely, Brandon. It's a more holistic approach. So what is our scope? You'll hear a lot about our scope. So you see the from birth, so from birth to death. So and I think this is a really great way to show us a lot of different diagrams of care. So in the beginning, when you're here, when you get your serious illness, um, and you're starting to feel poorly, you know, probably the medicine or the doctors that you're seeing will be able to manage that. And they may be able to manage, some of your discomfort, some of your social distress, your moral distress, all within the clinic, whether you're with a cancer doctor, heart doctor, lung doctor, they're able to manage it. And what they're doing when they're tending to you is providing primary palliative care. Those are the palliative care skills that we all just need to have in order to be healthcare professional. As that illness becomes more complicated, or if your social situation, your spiritual situation, your psychological situation is requiring more than what your primary specialist is able to provide. Though your needs are just outpacing, that's when you may get specialty palliative care. Specialty palliative care, again, as I said, is delivered by a team. So usually the structure is you have a doctor or an advanced practice provider, which could be a nurse practitioner or an advanced or a physician assistant. But most of the time, it's going to be a physician. That physician will be the leader of the team, because if you have a team, somebody has to lead, or you're just going to be walking around in circles and not knowing what's going on. But who is most important to the patient depends upon the need they have at the time. So patients will come into my clinic, and maybe their issue is that they're no longer able to get to their church, or that they're angry with God. And they will tell me that. Me not being a spiritual health clinician, I'm probably not the best person to address that need. So at that time, I step out of the room, and the bulk of the visit is managed through our spiritual health. And at that point, our spiritual health is providing the palliative care to the patient. And maybe I just see them for 5 minutes for medications. So but what I am doing as a physician is I'm coordinating that care. It's my job to know of all the team members what the patient needs at the time. Okay. As things start to decline, what I say is that the patient becomes more and more wrapped up in our care, where their specialty care becomes, it's still important, but it's becoming part of the periphery, because the specialty care is no longer able to meet the patient's needs. So what I mean by that is that if you are receiving treatment that's not helping you live longer or feel better, then that treatment's no longer helping. And what the specialist may have to offer you is no longer helping. So as that's happening, then we become more prominent in a patient's care. And it's almost like a little bit of a flip. The specialist usually doesn't go away. because the patient has a relationship and they serve an important role, but our role becomes larger. When someone is at the end of life and we are worried that they may die within 6 months, or we wouldn't be surprised. Again, there's no way to know, but we look at somebody, we evaluate them, and we're concerned that their time is short. That's when they enter into hospice care. And hospice care is an insurance benefit that provides all the same interprofessional team members I talked about, but it also provides equipment, medication, usually at no cost to the patient. It's all covered. And that and hospice care provides the most support for patients and families when they're at the end of life. So would I say that it's not less care, it's just more intensive care, but the intensive care is no longer treating the illness. The intensive care is treating the symptoms and the distress of those symptoms. And how healthcare providers are still involved is that doctors like me may continue to manage the patient in hospice care. We're doing it with a different team and a different point of view. And then bereavement. I do have some patients who had loved ones where my patient has passed away and their loved ones still come to see me. And why? Because they're having grief. So some of us will help with grief. And there's actually in palliative care a wonderful option as a profession. It's called a thalientologist. And they're actually grief and bereavement specialists. In Latin, there's probably a reason why it's called thalientology. And I took 4 years of Latin and I cannot remember. And please don't tell my parents. Okay, next slide. So what are we really? So I like to say we focus really on the 4 H's. First of all, we help. So whatever you need at the time, that's what we help you with. Hoping. We help people reframe their hopes. So when people have serious illness, and even when they're facing death, doesn't mean that they have to give up all hope. It means that, but what we do see is that that hope may evolve and change. So where that hope was, I want to live to see my grandchildren grow up. The hope may shift to, I want to see my granddaughter born. I want to take time. I want to have the strength and the ability to do these special moments with them. So hope just changes if somebody's going to live with a physical disability. And now, and they go from, being able to function in the world like able-bodied people, and then now they're disabled. That's a huge loss. And you see grief, and people sometimes don't really know how to have life beyond that. If you're born with a disability, you kind of understand that's all you know. When you develop a disability, there's a period where you have grief and difficulty. And if you're having lots of symptoms, that can be really hard. That's a big bucket of where people can start to have hopelessness and not be able to see the quality of life they can have as they're living with their disability. So we help with people with reframing hope. Holistic, we focus on the person, but we also focus on the family. And the reason why we do that is that people don't, in our country, we really believe in autonomy. We believe, the patient, what do you want? We're all here for you. But in the reality, if you have a serious illness, there's somebody needing to take care of you. And that person is now obligated by whatever decision the ill person makes. So if if my father has cancer, my mom is caregiver, she has cancer too. They're just experiencing it differently. And so their distress of the family members and the caregivers have to be tended to as well. Okay. So I say we're kind of like the Good Samaritans. We can't stop the bad thing. We cannot prevent the bad thing from happening, like in primary care. We can't deal with the future of the bad thing happening, like our surgeons and some of our other specialists. What we do is just deal with what is. We just take care of you in the moment, however you are. Next slide. So what's our philosophy? So palliative care is all about goals. All about goals. Like, what are we hoping to achieve? Is the treatment that you are getting going to give you the things that you want? And I often explain that to patients when they're trying to decide about, and I have lots of conversations about aggressive therapies or new treatments, and people are just kind of unsure. After you've been sick for a while, you kind of get tired of trying new things, particularly if so many things haven't worked before. But you still, you just kind of have to work through it. So what I explain to them is that we start with, first of all, what is most important to you? What are your goals? And what are the things you cannot live without? And then how you frame the treatment, that whether or not you accept it, is based on number one, is that what the doctors are offering? Can it give me what I want? And how much is it going to cost me? How much is it going to take away? And can I pay that cost? Because when you get sick, um, how the TV puts it, and I think from the vantage point of the care team taking care of you, you get sick, you have an illness, we cure it, we're high-fiving ourselves, we hug, we're all on Facebook, it's amazing. But afterwards, what we don't explain is that the only thing treatment can promise you is life, physical life. It does not it cannot promise you what that life is going to be like. So curing of an illness doesn't necessarily mean wellness. So if you guys have ever heard survivorship, where people talk about cancer and they talk about survivorship or post-transplant, that those kinds of, I'm a survivor of that. That's a really big deal because that part of care requires specialty too. So some of our palliative care providers will go into survivorship where they really focus on how do we help people who've been through something really difficult. The illness is gone, but they don't feel any better. And that's a huge gap. So it's like what we're doing, what they're trying to do is help them get to wellness. We are guides. So when I go into a person's room, of course, I'm going to have opinions as a person, opinions as a doctor, but at the end of the day, my goal is to support their goal. And we let them set those goals. And the other part of our profession is that we're okay with sitting with uncertainty. So for a lot of our patients, there is no answer. There is no answer. And that can be hard. Or if they have an illness and they're wanting to know what it's going to be like, or they want to know if their illness is going to come back. A lot of people, particularly like your cancer patients, you think of your breast cancer patients, breast cancer, they get treated, they don't have any evidence of disease. Now they got to wait for 5 years before they hold their breath for 5 years. Because within that 5 years, that's the time where the likelihood for it to come back. They take medication to help it not happen. But, they don't start sort of backing off on that care for 5 years and they live with that uncertainty. It's like being in an Edgar Allan Poe poem. What was it? The Pit and the Pendulum? You're just waiting all the time for the other shoe to drop. So we help people figure out that uncertainty. Next slide, please. So where do we operate in the medical system? Oh, yeah. We often operate when evidence-based medicine fails. So, and in many of the things that we do, there's growing literature for it, but we're often being very creative and we fit in where the patients are. Next slide. What's the model of care? The primary goal is to mitigate suffering. So we cannot prevent suffering. Because if you have a serious illness, there will be some suffering involved. Our goal is to mitigate it. And if we're not able to mitigate it, our goal is to stay with that person while they're going through it. We treat all those symptoms as the entity itself. So if a person's in pain and they have cystic fibrosis, or they have sickle cell, or they have cancer and their primary issue is pain, when they come to me, that's what we are focused on in the context of their illness. Therapy is medically indicated if symptoms are if it's going to control symptoms. So people will ask, well, if you're in palliative care, would you see a patient who's on a ventilator, or would you support that? And we're like, well, we have patients that have neurodegenerative disorders. I don't know if you guys have heard of ALS or Lou Gehrig's disease. Well, some of those patients live on ventilators and they have an acceptable quality of life. So if I'm taking care of them, I'm supporting that ventilator. So thinking about not what we take from people, the goal is that we're going to support things that are going to help people have a better quality of life. And sometimes that better quality of life means to get there, it means to have some aggressive therapies. Patients we view as complex beings. The treatment also has to be congruent with the values and beliefs. So when we have patients who have different value systems that may not correspond with our own, our goal is to figure out what is their value system and make the treatment plan that's going to fit what is most appropriate for them. We want people to live comfortably, and we value both objective as well as subjective data. Next slide, please. So how do we work? Well, it's all about a team. So there's not one person that can deliver it all itself. Like I said, the doctor might be the leader or the advanced practice provider, but we're usually working with social workers, nursing assistants or medical assistants, chaplains or spiritual health providers. Many places will have volunteers. There's pharmacists, nutritionists, therapists, where it could be physical therapy, occupational therapy, or psychological therapists. And for some programs, they even have pet therapy, which is awesome, which is helpful to the patients and helpful to us. Next slide. So where do we work? Again, we are in hospitals, we're in clinics, long-term care facilities, I mean nursing homes, specialty hospitals. We're in hospices, homes, insurance companies, right? Operating rooms, and we're sometimes even embedded in the specialty care clinics. So wherever the patient is where palliative care can be. Next slide. So we talked a little bit about the difference between palliative care and hospice. And so I think I won't read all of this to you, but the best way to think about it is palliative care is an umbrella, and underneath that umbrella, hospice is under that umbrella.
Hello.
And that's the palliative care we deliver
Hello.
to people who are at the end of life. Where when I'm in clinic, I deliver the palliative care to people in clinic when they're receiving active treatment. Next slide. Interprofessional teams. So how are these teams a little bit different? So as you see the list here of everything we talked about, you'll notice that hospice list is a little bit longer. The reason is the sicker you are, the more support you need. And a hospice in our country is the one benefit that is able to provide that wraparound support. So as you see all of these different positions, depending on where you want to enter into healthcare, there's definitely a place for you in palliative care, or in where we're seeing more people upstream, or within hospice care. Next slide. So why do I love my job so much? Why am I smiling every day? I love my job so much because palliative care is the perfect mixture of physiology, pharmacology, social science, human connection, spirituality, and psychology. So I laugh every day. They're like, gosh, if you're a palliative care doctor, most people sometimes think that all we do is have conversations, but in order to manage, if you're an oncologist, you really have to really understand and know everything about your cancer. If you're a palliative care provider and you have to manage the symptoms of the seriously ill, that means I have to know about the cancer, I have to know about heart disease, dementia, kidney disease. So, because you can't palliate something, you can't help somebody with something if you don't understand what's going on. So, it really does require, if you are a physician, if you really like complex medical care, you like puzzles, and oftentimes we're taking care of patients who may not want tons and tons of tests, then you really have to really understand. Physiology and medicine very, very well to make good decisions. There's tons and tons of pharmacology. So if you like medications, or you want to be a pharmacist, we have a pharmacist on our team. She's amazing. She's so helpful to patients and family members, explaining what the medicines are, looking for interactions. Social science, I always say that if you don't have lights or food, it doesn't really matter what your illness is. So if we can't help with your social determinants of health, so you can actually get your treatment, none of it matters. The human connection, we spend a lot of time making human connections, spending time learning about a person, about their lives, because people are not their illness. They have whole entire lives. And if you understand that and that helps you better understand the choices that they make. So you're able to support those choices. And again, as I said, spiritually, spirituality is so important to most people, whether they have a particular religion that's important to them, whether it's spirituality or even issues surrounding dignity and personhood that falls under spirituality, like these larger questions that we don't have answers to. And then psychology. Most patients who have a serious illness at some point may experience clinical anxiety or depression that need to be treated. Next slide. So again, we talked about who gets to practice, but I want you to look to the other side. So these are medical specialties who have pathways to palliative care. So if you decide, okay, I'm going to be a doctor, and we grab one of you, yay for our team. So we get one of you and you say, hey, I want to go into palliative care, but I really like delivering babies. I think I want to be an OBGYN, but I want to do some palliative care. Yes. So as an OBGYN, yes, you can do palliative care because GYNs do GYN cancer. And they also work with women who may have pregnancies where the child is not expected to survive. So that's as neonatal palliative care. And doing those consults before and supporting the family through their journey, and also understanding what they're going to be going through afterwards. What if you want to be a surgeon? Surgeons are great because, they're surgeons and we need surgeons when things go wrong. But there's a whole profession of palliative care surgery where people do surgery to relieve symptoms, and that's huge in our field. Again, we have children, there's psychiatrists and rehabilitation specialists. So these are all the specialties. I think the only thing I left off was anesthesiology. Anesthesiology has the subspecialty for pain. So many pain specialists are anesthesia doctors, and those are the doctors that help the surgeon. They put you to sleep, but they also do procedures for pain. And so pain and palliative care goes together really well. Next slide. So in our profession, the possibilities are endless. Next slide. All right. So what kind of jobs are available? Again, almost anywhere you can think of, but I want you to look at the last three. Public policy. So people who love advocacy, they want to work in their state legislatures. They want to, think about healthcare policy. There's a huge place for that. Palliative care is very active in healthcare policy and serious illness. Corporate healthcare, a lot of our docs make startups, apps, that do help patients with serious illness, but they have that palliative care background to really understand how can we create new innovations and technologies that are going to help patients with serious illness. So that's a really nice marriage. And research tons. We have definitely lots of palliative care researchers. So we have PhDs, people from public health, like in our institution at Emory, we have a whole section of health services research that really just focuses on palliative care. Next slide. So now let's bring us back to our patients. So what am I going to do for my 30-year-old mother of three, children under 10 with advanced care breast cancer who works as a pastor? Well, I'm going to manage her pain so she can care for her children and still work, because if you don't work, you don't have insurance, at least right away. We will help her obtain family medical leave to accommodate her chemotherapy treatments, right? Because you just can't walk away from work, and that requires paperwork, and it can be challenging in some cases. So we just relieve that challenge and we do it for them. We provide the counseling for depression and anxiety and help connect her with support groups for people who understand what she's going through. We provide resources for the children to help her discuss the illness with her family, right? So again, we sort of think about illness affects everyone, and the way children experience their loved ones or their parents with serious illness is a skill. It is something that we have to attend to because it's very destabilizing for the kids. So imagine being very, very sick and having a child who's acting out or becoming withdrawn. So we really want to make sure that we're helping families cope the best they can, and we provide those resources. We help her complete an advance directive. She has 3 children. So we need to know who her legal surrogate is, but we also need to have really difficult conversations about if she dies, who will take care of her children? And and I think that, conversations like that, very emotionally charged, hard to approach, but it's really important. We counsel her about medical cannabis. So you'll find a lot of our providers, like I do a lot of work with medical cannabis. I have a colleague who focuses on psychedelic medicines, and because that's becoming huge, and treating depression and death anxiety. And then spiritual health allows her to discuss her anger and frustration with God that she cannot express with her other pastors, and help her do meaning-making activities for her children. Next slide. So for our 92-year-old with dementia cared by her daughter, we explain dementia prognosis to her daughter and let her know what to expect. So you'll be really surprised that we're so good at telling people what they have, and we're so good at telling people what to do about it, but we often forget to tell people how it's going to go. And for illnesses like dementia or any of our neurodegenerative disorders, people can live with this for a very long time, years. So it's not caregiving for 2 weeks, a month, or 1 to 2 years. Sometimes people are caring for the loved ones for 6, 7, 8, 10 years. So it's very important they understand the illness and what to expect. We help her plan for her mother's ongoing care, because what happens if the caregiver goes down? Who's going to take care of mom? And there's no magical pot of money. The state provides, depending on where you live, will provide some resources, but often what people need outpace those resources. We complete advanced physician order for life-sustaining treatment. So an advance directive is something that you can complete as long as you have agency or mental capacity. If you don't, and your time is short, then physician order for life-sustaining treatment is a way to have your caregiver help and for you to sort of figure out what that care is going to look like at the end of your life. And those are usually done when when we're worried that prognosis is maybe about a year. We manage her mother's pain and agitation. We assist with family medical leave, again, for paperwork for her daughter. And we complete forms for her to access long-term care policies to relieve the financial stress. And we also try to look for caregiver grants. So we're very cognizant, because an illness doesn't just come with physical toxicity, it also comes with financial toxicity, which can devastate people. You think about, at some point, and this still may be true, that the number one reason for bankruptcy is healthcare cost. Healthcare cost. So if you don't think about that for your patients and you develop, you have these fancy treatment plans doesn't mean anything if they cannot access that plan. So we have to think about that. We have to be responsible to consider that as healthcare providers. Next slide. And for a 55-year-old with diabetes needing a heart transplant, that his feet's always burning and he's currently unhoused. We help him find stable housing and address food insecurity, and we work with his community caseworker. So this is a place where a palliative care team is not actually providing the food and fixing the food insecurity in the housing, but what we are doing is finding the community resources and helping him navigate and serving as the glue. Because if he's unhoused, it may be really, really difficult. If you don't have an address, it's really hard to access these services. He's already tired. He needs a heart transplant. So asking him to Google and fill out a bunch of forms is insane. You need help doing that. So that's what we do. We help manage his pain and other symptoms. We find him a primary care provider to manage his diabetes, because as a palliative care doctor, I don't manage diabetes very often anymore. What I know about diabetes, I ask the patients, are you one with the dancing guy? Are you one with the lady with the yellow dress that's twirling? Which medicine are you on? So we definitely engage specialists if we cannot manage those ourselves. What we're serving is as navigators. We advocate for him with the heart transplant team, and also we make sure that his wishes are known. We want to make sure that he has these option to receive a transplant. And if he's not able to receive a transplant, or he doesn't want one, we need to make sure that his wishes are known. And we build trust and help him connect with family and identify a healthcare agent, right? And if he cannot connect with family and he's going to be what we call unfriended, then we try to figure out what's going to happen and how do we connect him either with guardianship or with a friend that he might trust to be able to manage his care at the end of life. When we assist him with mental health resources, we help him complete an advance directive because we need to know what he thinks. And we offer dignity therapy. So what is dignity therapy? Well, dignity therapy allows people to narrate their lives. They talk in a tape recorder and they just tell us about their lives. And then what one of our team members do is they get that translated, get the transcription, and then give that back to the person. So, and what they are able to do is give that to someone they love. They can keep it for themselves, and that can be really meaningful. Believe it or not, they're historians in palliative care. So if you like history, you're like, I want to be in healthcare, but I like history. There is a place for you. You can be a historian, because what historians do is they do dignity therapy, but on a much grander scale. It may even be videos. There's a lady in Ohio who's amazing. She does videos and takes actual histories of the patient. So they're just not talking. She asks these questions. And as a historian, what she produces for people is absolutely beautiful and meaningful. Next slide. 5-year-old girl with aggressive leukemia raised by, and I said his, by her grandma. And we provide pain and symptom management, we support her. So sometimes what we're doing is translating, like, hey, I know what the doctor said, so this is what he actually said, or she actually said. We discuss possible outcomes and we validate hope and prepare for the worst. But we advocate for her and her grandmother's wishes. We help throw a birthday party in the hospital and actually bring in real princesses, because that's awesome. We manage symptoms after the treatment is over, because children, many children will survive their childhood cancers. And she now, as cute as she is, as she grows up, she looks a quality effect. So goes to help her integrate back into her life. And we still remember her birthday. She remembers at her elementary school. Right. So it's those moments where there's a lot of difficulty, but with a lot of joy when the little ones get better. Next slide. Okay, sorry guys.
Oh, you're done with the presentation?
Yeah, that was it. So apologize for my connection, but I hope that was helpful, and I hope that you guys see that there's a place, no matter what you want to do, there is a place for you in healthcare, and even if you don't want to be hands-on with patients, you can make a difference.
Perfect. Thank you so much. Now we're gonna go ahead and move on with our Q&A. So feel free to unmute yourself or type your questions in the chat. We will go ahead and read them for you. Yeah, so whatever you have a questions for our professional here today, you can go ahead and unmute yourself and ask it.
There is one in the chat.
Okay, so it says, since healthcare in the United States is already extremely difficult to access, have you ever had a situation where insurance did not cover the services that you wanted to provide? If so, is there a system, your clinic that has in your place that you can deal with these situations?
No, that's an excellent question. So in most and if you see a palliative care provider in a clinic or you're seeing them at home, just like with any other doc, you have to be on their insurance. So sometimes we have to get prior authorizations for our services. Currently, the only billable provider, and this is important, is usually the person like the doctor or the advanced practice provider. So that's the only person bringing in money. And that person has to support the other team members in a healthcare system like ours. In other healthcare systems, if you're in California, if you're in New York, you may have, or with Kaiser, these are systems that are accountable care organizations. So they look at the patient holistically and they provide services to help lower how much healthcare the person has to utilize and hopefully get the healthcare that they need and not, just extra. So we still, where I am, is a fee for service. If a patient is within our healthcare system and they need palliative care, we accept charity care. So that means that the healthcare system will pay for their palliative care. But yes, so we don't turn anyone away in our system. Sometimes we may not be covered by insurance, but we do something called a prior authorization. So if you do any shadowing of a doctor, just say prior authorization, and then you'll see us start to cry tears. Because it means that fighting with insurance companies to get what your patient needs. In hospice care, hospice is covered if you do not have insurance. Like we have migrants and people who are not citizens of the country. And so what happens when they get sick? Well, hospices can take them as well on charity care as well and provide, and when they're under charity care, they give them the same services that everyone else gets in theory. So there is usually a place, particularly at the end of life, to get really good palliative care. Our access problem is really not so much can you afford it? It's actually, is there enough of us, which is why I'm here begging you to consider it. Is there enough of us to actually go around? Plenty of us in cities, but in rural environments, like down, I practice in Arkansas, rural Arkansas, Louisiana, the Dakotas, all of those places, don't have enough providers. So that's what we really need. And I think there's another.
Perfect. Another question in the chat, how often do you experience working with children?
So I'm an adult provider. It is also trained as a geriatrician. So when I'm usually seeing children, I'm seeing them as a transition out from from the child system into the adult system. So we have people who they call them like AYA, so cancer survivors that may still be getting symptoms managed at child like our children's hospital, and then now they have to go into the adult system. Or there's some places where childhood illnesses will require something that they have in the adult system care. So that's when I will see them. But my whole colleagues, but pediatric palliative care is its own specialty. And with kids can receive concurrent care. So, many of these providers are taking care of kids for a really long time. They definitely work with children who are dying. That is definitely part of the job. But, they also are spending a lot of time working with kids who may be chronically ill or with the hopes that they'll get better, but just not right away. Okay.
Thank you. Another question here. After getting the required education and degree, was it easy for you to get the med career you wanted? Like, did you apply for it yourself, or did you have someone else help you for residency and all of that?
Oh,
Also, did somebody recommended it for you? Would you say that you were able to balance your career with your personal life as well?
oh, that's a great question considering my kid is downstairs and they've been like screaming in the background. Um, I won't lie, it's difficult to balance. So I think if we're really honest, I'll start at the back and move forward. I don't think of balancing my life. I integrate my life, if that makes sense. So instead of trying to block off this period of time and I'm going to do this at this time, you end up feeling like you're failing at everything. So what I choose to do is I integrate it. So if I'm playing a game with my kid, I'll play the game. If a patient calls, I'll let my kid know a patient calls. He usually has lots of medical advice to give on his own, but I'll take that call and I'll tell the patient. Patients ask me often what you're doing. I said, oh, yeah, I'm playing a game with my kid. And, but I address there and I hang up and then I go right back. There are going to be some days where I'm giving my family a 90% and healthcare 10%. And then there are going to be days I'm giving healthcare 90% and 10% goes to my family. But what both of them I realized understood, it took me a while to understand this, is that if the time I'm spending is really good quality time, quantity doesn't matter as much. Like I could be there, but if I'm on my computer the whole time, then I'm not really there. And if I'm with my patient, but I'm checking texts for my husband about, what we're going to eat for dinner, then I'm not really there. So I try to be present in those areas. But yeah, but it's always going to be a balancing act. But that doesn't matter whatever you go into. Now, who helped me? I decided, I think I mentioned when I was 5 years old that I wanted to be a doctor. And then my parents, that was it. I was set. So that was, I was like, ah. And so if you come from a household or if you come from a culture where that is what is expected of you, you kind of get on that path. And who helped? I took, before I went into and applied for medical school, I did do programs like this. I did pre-medical programs. I took advantage of all of those things. And why those were so important, it sort of introduced me to the work because, you're going to be worried whether or not you can do it academically, which you can totally do it academically. It's not rocket surgery, but we make you feel like it is. You can totally do it. But having those programs like in college, those pre-medical programs gave you confidence and it introduced you to the world. So one of the things you'll learn about any profession, um, the pathway is hard and rocky, but not everybody goes on the hard and rocky pathways. There are places which are smoother and easier ways to do it. If you do not come from a background that is privileged or a background where you're multi-generational, maybe in that profession, there are going to be a lot of things that you don't know. So when you do these pre-health shadowing programs, when you shadow physicians or or whatever specialty you want to go into, what you're really doing is seeing behind the curtain and learning the easier way to do that. You also want to make sure you get some mentors, people who have done this before to guide you, again, to show you you want to work smarter and not harder. And those programs helped. In college, I had a professor that really believed in me. So because my family was really worried about me going to a large university, I went to a small college because they wanted me to go to a small college, so I went. I really loved my parents. And it wasn't a prestigious school, but that I remember that Professor Dr. Therian looked at me. He said, if you come here, I will build the biology program around you and you will get into medical school. And now I could have gone to a more prestigious school, but if I had, I would not be where I was today. So you want to think smart. You want to think not about the name, but can you be with people who really care about you, who are going to sponsor you and get you where you want to be? Once you get into medical school, I tell people, you have to think about not only getting into school, but you also want to think about the cost, right? Can you afford to do this? So where you can go, and um, and medicine, an MD and a DO, once you're practicing, there's no difference. So if you're thinking about, so expand your horizons. So doctor, there are osteopathic schools as well as allopathic schools. You'll get great education. Am I get that?
You're good. Do you want me to move on to the next question? Okay. It's asking here, how does your team deal with situations where like the decision of the patient is a little bit different than the family's decision, especially where the patients come from a culture where the approval of elderly and health decisions are viewed as a family affair? Did you hear me?
Um, wondering if
Your voice is cutting.
are you all able to hear me?
Yeah. Yes.
It's really choppy. Okay, great. Yes, so I think that when physicians are reluctant to consult us, it's usually because they're not understanding the breadth of what we do. And that it takes time. So if there is a family that might want to see us and the physician is reluctant, what I usually do is I go to the person, to my colleague, and I tell them what I'm going to say. And then I ask, what do you want us to address? Because when you are working with people who are very, very sick, you want all your doctors to be on the same page, right? So it's not that I don't have my opinions, but what we do is we work it out before. Some families will not talk or see us, and that's absolutely okay. If I come into the room and I cause you more distress, then I'm not helpful, right? So eventually, there may be a time where I need to come in later, and that's okay.
Perfect. Thank you.
The palliative care is becoming the standard of care.
Mm, I think your voice is gone. Back. Okay, so the next question is, how are you able to keep your spirituality or religion separate from a patient who does not believe exactly as it, that's asking for or like looking for a source of hope? And another question they also had was, did you always wanted to do the specialty that you're working with, or did you have any other specialties that you were interested in?
Okay, that's a good question. For the spirituality question, you know, it's very interesting. Humans are very interesting. Um, if you're able to make a connection with someone, it's okay to be different. So I don't have to be the same of the same religion, but I have to respect that and respect and learn about that so I can take the best care of you. So sometimes patients will ask me to pray with them, and if it's not appropriate for me to do so, I may not pray. I may say, I'm not able to do that, but I can be here with you while you pray. Does that make sense? So you don't
Yes.
have to change who you are to care for people.
Thank you. And the other question was, did you always wanted to do palliative care, or did you have another specialties that you were interested in taking in?
In
I think your voice is gone.
Oh, yeah, no, I
There you
had
go.
no idea I would be a palliative care doctor. I did my, yeah, I had no idea I wanted to be a palliative care doctor. And when I started, this,
I think you're gone. I can't hear you. Sorry, guys, about the difficult. Yeah, I can hear you now. I think you're gone again.
okay. Hey guys, are you able to hear me now?
Yeah,
Oh, wow, I really said something amazing. So,
sorry,
um,
I don't think we heard it.
but no, no, when I started, this was many years ago. I won't tell you how long, you know, this wasn't a popular profession. Um, when I found this profession in residency, my advisor said, "Oh no, Kim, you can't make a career out of that." So I went and became a hospitalist. And it wasn't until working in the hospital and realizing, and I loved hospital work, I loved the ICU, so that was probably the pathway I was going to go. But what I realized is I wasn't able to care for people in the way I wanted to. And I didn't feel as though I was making a difference. People would come in, I would treat them, they would see the same person over and over again. And one day I asked a patient that probably admitted 10 times, and I said, what is it that you want? And I didn't even ask it in a palliative way. And she told me she wanted to go to the beach. And I said, well, maybe we can go to the beach. I didn't know. So as a social worker, I said, she wants to go to the beach and she has these things. Social worker's like, well, yeah, we can talk to another company and they can, make sure she has, all of her medications. And we were able to help her get there. And then it occurred to me, oh, because when she came back, and of course she got admitted again, her whole attitude towards me had changed. And it really had to do with is that for once we listened. We listened. And when we listened to her, she was a lot more compliant with what we were asking her to do, if that made sense. So it started to click. And then I became a hospice medical director, and I really didn't know what hospice was because they just asked me, and I never say no to anything. And I was completely shocked when I found out, but I realized I loved it. So I kind of fell into this, look back.
Perfect, thank you. Another question here, when does a palliative care team really get involved together with patients through their illnesses, especially like having an entire team maybe each one might have different ideas on how to approach it or different ideas to put into it. Like an oncologist, they give an example here, wanting to continue with the higher dose, or maybe another one would say a different idea. How do you guys all come within like one decision when it comes to a patient? I think you're cut again.
Um, it depends upon the ideal would be for us to enter into a patient's care early. We would love to be there at the time of diagnosis. That's not always possible, and it's not always needed. So I think the best way to use a palliative care team is thinking about need base. When are we starting to see distress? I think we should introduce palliative care or introduce the palliative care team early and the healthcare process.
Thank you. Another one saying here, many students have shown that picelopsine treatments have very positive outcomes for palliative care patients. Do you have any opinions on that?
It is
So,
psilocybin. Psilocybin.
psilocybin. Yeah,
Yeah.
I have at Emory a colleague that studies psilocybin, and that's part of his work. Yes, it psilocybin is one of the things that have shown to be effective for patients who have depression and cancer. So I have a positive view of it, just like everything else. We have to be careful and we need to do research to really understand the longer term effects and to understand it better. So we give it to the right people and we do it in the right way. We also don't want to remove the spiritual component of it because, it's really used um, spiritually, and we don't want to remove that and medicalize it so much that it loses its effect.
Thank you. Another question. What was one thing that have surprised you about the process in your journey of becoming a physician?
Oh, so many things have surprised me. That's the one thing that surprised me. How quickly it went. How quickly, like I can still remember how quickly the time passed. Um, I think I was also surprised by oh, I think I might have lost you. I think I was also surprised by really getting to see humanity in a different way. I started to, and how much I've grown and matured, and how much I have learned from working with my patients and with my colleagues. It's really a privilege and it's a joy to be in this profession and healthcare in general. Like you see people become their best selves. You see people rise to the occasion. You see people who, suffer greatly and are able to process it. You see people who can't. But I think that it's hard not to fall in love with humanity again, um, doing this. It really makes you, really remember how wonderful humans can be.
Thank you. Another question here. If you had to do your medical school all over again, would you follow the same path or would you do anything else differently? Also, what advice would you give to your younger self?
I would tell my younger self, it's going to be okay. It's going to be okay. Um, would I do things differently if I knew? I think about that, but I think where I am in life now, if I did things differently, I wouldn't have, the career and the family that I have. So I think how I did it was really important. But what I would advise you all is to really think about, is this something that you want to do? And not be afraid to explore and to change and to really go to have the kind of career and life you want. Like you may start off on one path, and when you find that path is not for you, then it's okay to make a change. The good thing about, I think, about healthcare is that you have the ability to do that. It provides you with this stability. So if you want to be right, if you want to, you can evolve and grow. So that would experience and trust your doctor a lot sooner if I had trusted my instincts. And but those I think are the two most important things. The other thing to think about is your finances. We talk a lot about getting into school and doing these, the school and following your passions, but it's a whole lot easier to follow your passion if you're stable. So I tell people really think hard. Um, Go to the sessions that they offer you on how to manage your life and how to manage your future, but don't neglect that part. Don't neglect that part because it's so much it's so much better to do the things you want to do versus something that you have to do because you're trapped financially.
Thank you. We have a good question for PHS. So yeah, for the shadowing sessions, you guys will able to get a certificate after. We will have a quiz up ready for you guys on the website right after this session, just a few minutes after, where you guys can take it, and then right away after when you pass it and you get around 70% or up, it's multiple attempts as well, but you will right away after when you pass it, it will allow you to download your certificate with your name and the hours from today. And for the recordings, all of our recording will be up within 24 to 36 hours on the website and as well as on our YouTube channel. We also have all of our previous sessions, so you can always go ahead, take the quizzes for the previous ones, and download the certificate as well. Another question for you, Doctor. How do you see the field of palliative care evolving in the upcoming years? And are there some things that you think need to change in this area of medicine to make it better?
Yeah. What I see is an evolution to getting palliative care skills and training in medical school. So people are leaving with many of the skills that I have because we're never going to be able to produce enough. I also see us guiding more policy and moving into chronic illness. So, of course, you sort of think of palliative care and cancer, but where we can make a huge impact are really people will be living with serious illness, people who have multiple illnesses, like in primary care, and managing those symptoms and providing that kind of support. I think there's going to be a lot more home-based where people are being given this kind of care within the home. So that's kind of where I see us. I see us moving firmly into the community, moving into healthcare leadership to try to figure out population health, um, and us to be thinking more about chronic illness and how do we train the next generation to have good primary palliative care skills.
Perfect, thank you. How has your identity translated to providing effective care to different demographics?
That's a really interesting question. So, and I get that, I get that a lot. I'm an African American woman, and I know that, when I'm working with particularly other African American women, that just based on life experience and, we share, certain things in common, certainly not everything. And it allows me to have a conversation that might be a little bit different and a little bit of a different cadence. But the truth is, when I'm working with any demographic, I don't sort of think about it like that. I think about it as I'm talking to another person. And I try to practice the best I can cultural humility and allow them to tell me about themselves. And then I conform to that for them. Um, and you'll find that groups of people dislike groups of people, but a person really likes another person. So you'll find that the connections, because you're just not one thing. I'm not just my gender or my race or my ethnicity. I'm a lot of different things. So even if I cannot connect with a person based on maybe religion, I can certainly connect with a person if we both have kids. There's usually, because humans, there's not that much different. Humans, we're all not different species. We're the same species. So there's usually something that you have in common, a place that you can connect. And when you find that connection, then it's not like those other things don't matter. And you can learn those other things. Um, yeah, and I think and the people say, how should I talk to my Black patients? And I'm thinking like, well, I never got a toolkit on how to talk to my white patients. You're talking to another person. And even if you don't get it perfectly, if that person knows that you really care, they will they will accept you oftentimes as you are. So that would be something to really think about. Like when you walk into a room with somebody that doesn't look like you, um, don't assume you can't connect or you don't have something in common because you probably do. And then you spend time allowing them to reveal themselves to you.
Thank you. Another question here we have, what are some unique challenges and also requirements in providing palliative care?
Some of the unique challenges, there was one talking, I think about medicine before. Managing pain in this environment is difficult, particularly with the opioid crisis. So that has been challenging, and we've had to learn a whole new set of skills on how to manage people with serious illness, with medication misuse disorders or substance use disorders, and that can be really hard. I think what's also challenging is taking care of people who suffer from mental illness because that brings a whole other um, layer of support that they need, and not only psychological support, but social support. And, depending on where you live, those supports can be different. So I think that part is challenging. I also think depending on what part of palliative care you are in, presents its own challenges. Like I said, I love my job. I love what I do. We do sit in suffering quite a bit. I sit in a lot of joy, but there are times I'm sitting in suffering for really quite a long time, and that can take its toll. So I think having breaks and being able to have spaces to debrief for things that are really hard, and that hit you, kind of hard. So I think those things. How do you do your self-care when you're sitting in suffering, for extended periods of time? And how do you manage, these populations, these very vulnerable populations of people with substance use disorder, mental health disorder, our patients who are unhoused, and our patients who are justice involved. We really have to figure out how to expand there.
Thank you. We also have another question. How do you help patients and families get through the decisions when they have disconnected treatment?
So a lot of listening and patience. And when we're having these conversations, like when I go in, I try not to go in with a preconceived notion or what I would want for myself. What I'm really trying to figure out is what are they hoping for, and making sure that they have all the information to make the decision. So I spend a lot of time listening, a lot of time reframing, and a lot of time being honest. because sometimes if patients don't know the whole story or really understand how anything works, this is why if you're going to be a palliative care doctor, you got to be really good at your medicine. You got to know what you're talking about. Because when you're able to explain that to families, it makes a difference. Oftentimes they're making decisions based on erroneous information. And when they have all the information, um, it allows them to make better decisions. So, Sapaga, I'm not quite sure which part you missed, but basically, the steps to helping a family through a difficult decision is number one, understanding what they know, listen, 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 then listen some more, making sure they have been fully informed and understand. And then once the decision is made, providing acceptance. Because even if they choose a harder way to go, or they choose something I wouldn't choose, if that doesn't work, you'll know. You'll know. I tell families, well, if this is what you're hoping for, we will try that. If that is not working, then this is what we have. So we want to always make sure that we're aligning with their values and goals. And that can be hard. But you can only do that if you walk in ready to listen with the only goal is to have them do something they're going to be able to live with.
Thank you. We have another comment here in the chat. I imagine how these conversations with the families could be difficult at times. Have you ever experienced struggles or hardships in these conversations? If so, how do you work and come around them?
Yeah. Oh, yeah, a lot of emotion when people can be very angry. When people are stressed and tired and afraid, some people respond with anger. So people have, said, very, very difficult things, even things that are hurtful. And what I have to remember in those moments is that number one, whatever's happening right now, it's not happening to me. I get to leave. They have to live with this. So whatever I'm receiving is their grief and their distress, and how they're expressing that degrees and grief and distress is that they attack. And when somebody is sort of attacking, um, if you can wait long enough and stay long enough, as long as it's not, too bad, um, they eventually get all of that out, which allows them the opportunity maybe to hear. The other thing is really learning to accept what they choose. That's the hard part, I think, for healthcare providers. When people choose things we would not want or choose for ourselves, it's very difficult because we're looking at suffering through our lens. I try to look at the situation through either the family or the patient's lens, try to really incorporate what they're saying to kind of understand how they constructed their decision. And then when you are able to do that, it allows you to develop trust. But it takes a while. It takes a while. So the best thing I say in those situations when it's really hard is don't leave. Don't leave. Continue to make yourself available, but be willing to um, work um, through the difficult part.
Thank you. We'll take on our few last questions here. One asked, is a referral from a primary care required to utilize services for palliative care?
It all depends on your insurance. So yeah, there's some places that require a primary care referral for any specialist. And then other insurances like Medicare, it's open access, so you can go to any provider that you choose to go to as long as they're in network. So not always. Most of our referrals come from subspecialists, which they're not their primary care doctor, but it might be their cardiologist or their pulmonologist.
Thank you. We have another questions here about the medical school journey. What would you say is the hardest part? How did you come over that? And how did you come over like the financial part, about like the loans or finding scholarships or all of that to cover it up?
Yes, so scholarships, if you can find them, I would apply for them. Anything that you can do. I think what was the hardest part? I think the first 2 years is the hardest because there's so much information and you often not spending as much time with patients. Medical schools have really evolved since I was in medical school. So it's not so much lecture. There's a lot more practice-based learning and a lot more autonomy. But the first 2 years are hard because it's just a lot. There's no way to cut it. There's just tons of information you have to learn in order to even get to where you want to be. So that part is stressful and there's tests. Financially, I just paid off my loans. Um, I think last summer. So I was 49, so I paid him off before I was 50. So, so that can be, that is challenging. So if you have a choice when you're thinking, I say really think about when you're choosing schools, and maybe you will get into multiple schools like many of you will. Um, Thinking, am I making a choice that's good for my career? But am I making a good am I making a good financial decision? The other thing, if you really like primary care or women's health, like an OB, there are several programs where if you are willing to practice in a rural environment for like 5 years, they'll pay off some of your loans. And then when you go out to get your first job, you can often negotiate. And I think negotiating loan repayment is really, really smart. Um, because right now we have a job and we just take whatever we're given. But when you are a physician and you're actually going to work, really thinking about putting some of that in there. And when you get your first job or your resident, you do not need a BMW. You do not need a fancy bag. You don't need to live in the fanciest spot in the penthouse. Live a few stores down and buy a used car. You will be able to have all those fancy things, but you can't have them right now. And also be leery of credit. You want to have some credit, but be leery of credit cards. If you're living on credit cards, you're living outside your means. So I would encourage everyone, if they can, to get a financial advisor. Sometimes they provide those in medical school. They can also provide those in residency.
Perfect. Thank
But
you so
yes, if you can get a
much.
scholarship, get it. If you get a full ride, you go. Okay?
For sure. Thank you so much for everybody for asking all of these questions. Again, if you have any more questions, I don't want you to keep them inside of you. This is for you guys to learn, for us to gain as much information as we can. So if you have any last questions, you can go ahead and say them. No, we can just move on. Yeah, so for the quiz, it will be up right after the session, just around 10 minutes, because we do the questions throughout the session, based on what we just discussed. So, yeah, you do not have to be just fully live to get the certificate. It will be the recording, the slides, and all of the information about the session. It will be posted on our website and the YouTube channel. So if you missed anything or any part, you can always go ahead and rewatch it, do whatever notes you want to do, and it'll be all up to go for you guys. So the quiz, it will be up right after the session, just like around in 10 minutes. And you guys will be able to take it. And you don't have to take it just right now. The quiz is going to be live forever. So if you don't want to take it now, you can take it later, tomorrow, whenever you feel like you're ready to do so. And for the certifications, they all are signed with the title of the sessions, with the name of a professional, and the organizations. But if you ever need any the contact number to put it, if you're applying anything, you can always feel free to write our contact information. You could put our email or our founder's name or mine as well, whatever you feel like you need up to do that. But yeah, any questions?
Yeah, I just want to say thank you all, and I really hope to see some of you because you guys are my retirement plan. So, so, but no, I wish you all the success in the world. Good night,
Thanks.
guys.
Thanks so much for being here.
You're welcome.
Thank you. And then you guys, our students, thank you so much for being here as well. It's very awesome to have as many as of you.
Thank you.
Of course, you're welcome.
Thank you.
Yeah.
Thank you.